and it's an excellent topic. Everyone knows Dr. Simpson. He takes care of everyone, not only in the community but the county, but all surrounding counties as well. So we appreciate him taking time. He's very busy out of his schedule. It's a great topic. Women's health, breast cancer awareness, etc. So with that, Doctor, I know you know everyone here. I'll turn it over to you.
Thank you. Again, welcome. Good to see everybody here. Hope you enjoy your lunch. It looks really good. And let's talk about something that's really important and life-saving. How many of you were here when I gave this presentation last year? Anybody? Last year we talked about types of breast cancer and touched on some screening and risk factors. And there's been some changes in research. And what we're going to emphasize on today is really what cancer is and the role that heredity plays in cancer. And it's really important. I don't know, those of you, you know, my family, I have a daughter who's young that has breast cancer. And this is a topic that's, you know, close to my heart, and I want everybody to understand. This is just a little piece of a great big pie about breast cancer, but I want to try to explain something to everyone here. And it may not, there will be some people here this will affect, but I can tell you there's a lot of people that this will affect your kids and grandkids and the things that need to be done earlier instead of later, okay? What is cancer? I mean, people think about this and they think it's something just different or foreign that comes into our body. Well, it's not. Cancer is when our tissues, the genes in our tissues that make up your breast and mammary system have mutations. Now, mutations happens all the time. As we're growing and getting older, we have mutations that happen, but our body has a system that takes care of those mutations, natural killer cells that takes care of that, and as our body, the cells die off, and we have killer cells that just gets rid of the bad stuff, resplices the new stuff, and it's good. But I'm going to try to keep this where everybody can understand it, okay? I'm not going to go into a lot of technical detail, but I am going to try to explain this for you, and that's difficult sometimes. But please stop me if this is something you don't understand, because I do want you to understand this, okay? So cancer happens when mutations happen and they don't get corrected, and then we start having cells that grow out of control, move about the body through the lymphatics and vascular system, and cause cancers in other parts of your body. I mean, that's called metastasis, okay? That's where the cancer spreads. What I want to talk about today is the importance of heredity in these mutations. When you see cancer in a very young person, that means that there's something really wrong with their system, that the mutations are not being taken care of. And so they usually have a gene, like a BRCA gene. There's some other ones that I'm going to give you all a website to go to that really lays all of these out really well, so you can understand it and know the importance of early gene therapy and gene treatment, okay? It takes a long time, a very long time, for cancer to develop in a person that their genes are working properly, okay? They, usually you see these cancers in women in their late 70s, 80s, and that is something that we can take care of, and usually those things are taken care of pretty easily with surgery and treatment, okay? And there's some hormones that relate to that too, to a certain extent. But what we're talking about is trying to get these young women in that have a family history of breast cancer and getting them diagnosed early, okay? This is some of the important things that I want you to understand about examinations and what your doctors are doing to make sure you don't have breast cancer. I know for a long time, and many of you know this, that self-breast exams we've been taught that and taught that and taught that, that's really important. And it still has some benefit, but the studies show that there's no decrease in morbidity in women that do self-breast exams. What does help is clinical breast exams by your doctor or nurse practitioner, and getting screening mammograms. But in women that have high risk and hereditary factors are high, they're even going as far as recommending an MRI now. Okay? Combination of clinical breast exam, mammogram, and MRI that increase the rate of finding early breast cancers are so much higher. So much higher, like 90%. Add in ultrasound, which there's some talks one way or the other about the benefits of that. You could probably add another 5% on that, especially in women with young, against breast tissue that has to be looked at. Now, I can tell you here at our hospital, we have both MRI and digital mammography, which is really good. I mean, this is the state of the art. This is the things that we need, and we have it here, and I'm proud of that. The fact that doctors, and when I was trained, this is what we were taught, that we only ask about first-degree relatives, and only the females in the family. Okay, so my brothers and sisters, moms and dad, or moms that have breast cancer, that's what they're looking for. Okay, but that has changed. We know now that through all the gene therapy, the gene research, that this is easily as passed down from the father's side. So you need to understand your history from both your mother and father's side of the family, and this even goes back to aunts and uncles and even further distant relatives. I can tell you in my family, there is only one case of breast cancer, and that was diagnosed in the 80s. And like I just said, it takes a long time to develop this, and it's probably was not because of bad genes that caused it. I mean, there are other factors, and we'll talk about that just a second. So, there's no telling where this come from, but it didn't come, I mean, there was no significant history whatsoever on both sides. So you really, really got to expand the history taking that we do as doctors, and we got to identify these young women that have risk factors that are increased because of heredity, and I highly recommend mothers that have daughters and the mothers that have breast cancer getting the genome testing done soon. Okay, there are other factors that help play into the development of cancer. Environmental, exposure to radiation, exposure to heavy metals, exposure to cigarettes, exposure to foods and the things that can cause breast cancer. There are elements of hormone therapy or hormones. It doesn't have to be therapy, it could be your own hormone, that can increase the rate of cancer growth, but they don't cause cancer. I want everybody to understand that. They do not cause it, they increase the rate of growth. Okay? The cigarette smoking, if any of y'all know me, you know why. Don't do it. Just don't even think about it. But some of us do. I think we pay the consequences sometimes. Sometimes you get away with it, but I don't recommend it. Okay? There is an issue with this, I think, globally, as far as women's health goes, about the gene testing. It's expensive. It's really expensive. And some insurance companies don't pay for it. But I think that it's important, if there's any way you can get this done, find a way. There are a lot of resources out there that do help with these kinds of things. I know I can think of one organization right now that I was kind of surprised, but I was so happy that the National Cowgirl Association is a big contributor to breast cancer, which I was really proud of. But that was, they helped my daughter, and I was really proud of that. We as doctors will try our best to find help for you, and other organizations, hospitals, Rhonda, Breeze back here. I mean, there's a lot of resources out there that we can help you with. Not as many as we need, certainly not as many as we'd like to have, but they are there, okay? And we try to help everybody we can. Now, let's talk about the exams. I mentioned that, just self-breast exams are not adequate, especially for someone at high risk to have hereditary components. Now, again, it's a broken record, okay? MRIs is still a relatively expensive test, and I get that. But and some insurance companies still will not pay for that, even though those risks are there. So try to get that done for your friends and family that have those increased risks, and so we can get early diagnosis. Now, what do we do about this? Is there anything we can do when we identify heredity of breast cancer that makes this person highly likely to have breast cancer? Well, there are. I mean, sometimes we find these a little too late, and we do, for instance, we'll do a mastectomy, and then sometimes we'll go ahead and do a simple one on the opposing side just to reduce those patients' risk. And I do that a lot, because women are becoming more and more aware that their risks are pretty high if they have it on one side. The risks are pretty high of getting it on the other side. So we'll do that a lot, and then they'll choose to do reconstruction at a later time, which I recommend. But there are some women, some young women, that have a really high expression of mutations in their genetic makeup that make them at super high risk to have breast cancer. And what do? Well, there's a procedure called a prophylactic mastectomy, and there's several different ways you can do this. You can do skin sparing, which you go straight into the same procedure, do reconstruction at the same time. There are simple mastectomies where you don't do the skin sparing. There are there's a nipple sparing procedure, and there is what's called a sub-Q mastectomy that can be done. Now, I know the question now is, what type of reduction in risk does that get you? Okay. About 90%, which is pretty phenomenal. I know for a long time there was a trend of not doing any surgery on people with breast cancer, just doing a little here and a little there, but the numbers have changed. Doing a mastectomy, prophylactic mastectomy, it is really the thing to do for these high-risk patients. I know that it's a very personal thing for some women. I mean, this is something that I deal with all the time. I mean, I get reports, and I see that there's a possibility of cancer. And you just see, you just want to, snap your fingers and make this go away for the women. You just can't do it. So you have to do biopsies, and when it comes back, you have to sit down and talk about all the options. And get chemotherapy, radiation, surgery, and what type of surgery, and it varies for everybody. This is something that it's very individual. It's very personal for a lot of people, and we try to respect that and get them taken care of as soon as possible. Now, I have great admiration for the larger institutions that do the research, do all the work, genes and research in numbers and research in types of procedures, and they're needed. But do not discount the surgeons like myself that are out here doing these types of procedures and this type of work in our own community. I mean, sometimes, I'm not gonna say we're better, but I can tell you this much, we are as good. And, we add the personal touch to it. It's different when you see people and you've never seen them before. And when you see people, you go to church with them, you go to school with them, do activities, sporting activities, you see them every day. And as a surgeon, I can tell you, if you drive by a cemetery, and you think about it, you always think about what kind of done different. And that's the difference between here and there. And I want everybody to understand that. We've been very fortunate in this community to have a lot of people that donated money, resources, and aid to this hospital. And they should all be commended. But we have a really good hospital here. That's true. Unfortunately, a lot of the gene testing and stuff has to be done in bigger centers, or we have to send the tissue samples off to bigger centers and get them evaluated. We can't do that here because it would be millions of dollars of equipment and stuff that really, wouldn't be economically feasible for us to do that here at this hospital. So right now, we're very well equipped to take care of the screening tests with our digital mammography. We do have MRI if we need to do that for our high-risk patients. We have ultrasound if we need additional images in that regard. We're able to do biopsies. We can do ultrasound guided, CT guided, needle localizations with excisional biopsies, which I prefer because I like to get all the tissue out. And there's arguments one way or the other, but I like to get the whole suspicious lesion out and have it analyzed versus getting a little piece of it, because there's just, you can miss a little piece and then later on down the road it can be bad because you think it's over with, but it's not. So listen to your doctors. When you have a history, when you offer your history up to your physicians, if you're concerned about your breast, you've had people in your family that have had breast cancer, no matter whether they're your sister, your brother, or your mom, say your aunts, uncles down the road, and on both sides, both male and female sides of the family, this needs to be conveyed on to your physician. Try your best to eat well, try not to smoke. If you can, if you encourage your family or friends not to do that, it does increase their health benefits. So, I just wanted to make this point today, that when you see young women, when they have bad lesions, it's usually hereditary, okay? And we need to identify this, and so their children, your grandchildren can benefit. So if any of you have had breast cancer and you have daughters, it's important that they get screened and early. And I can't tell you, the expense is significant, but the genomic testing is very important. There's a website called knowbrca.org, and I'll write this down so you can all copy it and go on that. And it really is a good display of information that you can look at and help you. It is explained in a way that most everybody can understand. And I think that is a great thing. As doctors, we oftentimes get caught up in technical jibber jabber. People don't understand it, and they will always go like that. But I want you to understand. So at this point, if there are any questions, I'd like for you to ask. Did everything I said make sense?
Yes.
Or not?
How old do you recommend they get the genetic testing done on a high-risk girl?
If you have early onset of breast cancer in a parent, I would recommend that they wait no late till about 20 years old. it doesn't hurt to do it sooner. Sometimes, you know, if you have a daughter that's, you know, oftentimes by the time that girl gets to be of age to have anything done, that's about when it falls into 20. Okay? Yes, ma'am.
Did the human papillomavirus have anything to do with that?
No, it has a lot to do with cervical cancer. Okay? Now, I can tell you that in conjunction with treatment, another recommendation for treatment with women with high risk is also having their ovaries removed. That adds probably another 5% of that, you know, when I talked about prophylactic mastectomy being 90%, having your ovaries removed adds only another 5% of decreased risk of breast cancer. Okay?
Dr. Chadwell told me he invented a new way.
A new way, huh?
He only takes out a fourth of the breast,
Well,
like where the lymph nodes.
now that's an old way.
Uh-huh.
We've got some different things. There are some things called stereotactic biopsies, and there are some sentinel node biopsies that they're doing. There is some discussion about that. It sometimes is beneficial. There have been a lot of cases where I actually worked in a study group in Fort Worth that we did these. We did a sentinel node biopsies on patients, and then we went ahead and took all the nodes out of their axilla, and sometimes we didn't get them all. Most of the time we did. But, and there's a lot of data out there that will, you know, that goes for that. But, you know, all of us doctors are different, and we're individual, and have worked on some of that stuff myself and seen some of the results work like what we would like to see them. I still feel like taking the axillary content out in a modified aspect, not taking the muscle, but just taking the lymph nodes out in the affected breast that has a cancer, a known cancer in it. I still favor that. Now, knock on wood, in my practice, I've never had a patient have lymphedema. And that is some of the risk of doing that entire axillary content dissection.
Other questions?
Carolyn wants to know what the axilla is.
Your armpit, all the lymph nodes in your armpit. I think Mary really wanted to know.
She did, yeah, she asked me, and I said, ask the doctor, he'll explain. Well, when you said you have to quit smoking, she said, do I have to give up my snuff?
That'd be a real good idea.
I did say that.
Yeah, smoking cessation or tobacco use is something yesterday, and this is completely off the topic, okay, but I'm gonna tell you anyway, because I know a lot of you have sons that did. Okay? I had a young fellow that come to me about a year ago, and hip snuff pretty bad, 25 years old. I did a scope on him, and I did 2 scopes on him. I did one, and the pathologist said, well, so I took him back immediately. A few days later, did another one. He did have gastric cancer. And he said, this is most likely from swallowing tobacco, you know, because he had it in his esophagus. He was in my office yesterday, it's been a year ago. He weighed 226 pounds a year ago. He weighed about 109 pounds yesterday. And he's been through a lot. I'm about to scope him again to see if he's had a recurrence of his cancer already in less than a year. It's bad. And trust me, I did. I just recently celebrated my 30th year of not dipping, along with marrying my wife. because she said, you'll never do it again. And that's probably the only thing I'm confined with, that she makes me do. But anyway, she'll tell you that. This is bad. And we see, I mean, why did I do it? My friends did it. And now when I smell fresh cut hay, that's all I want to do is eat it. When I don't, I get some beef jerky and going down the road. But, yes,
Did
ma'am.
this young guy quit?
Do what?
Did he quit? The young guy?
Well, he did because he can't even hardly eat food now, much less get. Okay. He eats probably less than a total of 10 fluid ounces of anything in one given day now. Because of just the pain that he has when he tries to eat. All the surgery he has and been through 3 surgeries already. And it doesn't look good. It doesn't look good at all. And we see this a lot. I see it a lot. So sometimes it makes my job pretty depressing when I see this, especially young people. But this is just the way it is. Despite how much we talk to people and tell them and try to convince them that it's just bad for you, but it's, they don't get it. So it happens. But
I've been reading about the free radicals. Can you tell me what I'm reading? I don't understand.
well, there are a lot of contributing factors to development of cancer, and there are a lot of things like people, like for instance in Japan, their food sources are mostly smoked and fish and stuff, and they do that for preservation because in rural Asia they don't have a lot of refrigeration. So there's a lot of free radicals that are developed through the smoking process, and I know we do a lot of smoking here in Texas, but actually we still don't eat as much as they do in Japan. Their gastric cancer is just over the top because of the things that they eat. So that goes back to the contributing factors, food, environment, the things that cause exposure to radiation, exposure to the sun. There's a lot of things that are contributing factors.
I know over the last couple of years, the hospital's really been focused on women's health. So we have state-of-the-art equipment now. But there's ultrasound, there's DEXA scan, mammography. And so this is something that we're well aware of. And I know this month, Gina and I have been on the radio a couple of times, or once, discussing Breast Cancer Awareness Month and the need for screening. A lot of information in the paper. We're scheduling, we have an employee day where we're scheduling all of our employees for mammographies. So if you haven't, we can do that service right here, and then fortunate, blessed enough to have Dr. Simpson here, our general surgeon, that can also help us when we get into that situation that we can call him. So, it's all right here within our community that we can do this. So,
Well,
keep that in mind.
Hope you enjoyed your lunch. Is there any other questions? Yes, ma'am?
They grew a human ear on a mouse. Cellophane. Do you think the gastric parts will pretty soon?
I think that's still in the long future. I can tell you that you mentioned that there are some of that technology that we actually use all the time on cancer, is that we take the tissues that we remove from breasts that are cancerous, and we actually grow them, reproduce those in the laboratory, and that way we have those tissues that we can test to see what actually will kill it. And we do that a lot. And we also test it for types of receptors it have, whether it be hormone receptors, progesterone, estrogen or progesterone receptors, HER2 receptors, and then we do that now. But we don't grow total parts as per se, but we do grow tissue, and we're able to test that tissue and have tissue to test to see what actually we can use to treat you with, and that happens all the time. Some of the more interesting cancer research now that's coming out is we're taking tissues and we're actually piggybacking other genes on a virus that will attack the tumor. And we put the virus in you that have these special genes in them that have a tendency to attack certain tissues, and they're attacking the tumors. And it is very successful. I can't wait until it comes out, because I know with some of the cases that I've been following pretty closely, there was one brain tumor that was reduced to almost nothing. And I think that it probably will be reduced to nothing. There are some other tests. A lot of this is going on in Houston. Some of it's going on in Canada, and different places. But it is happening. It's very exciting. Gene therapy is going to be, I think, the big wave of the future treatment for a lot of stuff, especially cancer. So, family history, we've got to expand our family history. So when you go to your physician, try your best to investigate all your family, both on the maternal and paternal sides of your family. Deeper, down the line, not just immediate family, and find out the history. That will be very helpful. Okay? All right. Any other questions? No?
Give us the website again.
Okay. Actually, I'll write this down and I'll pass it out.
Oh,
for you,
okay.
Okay. It's nobrca.org. I went through the whole thing last night. It was really good, and I wanted to share it with you. Make sure you had it. Thank you for coming.
I just wanted to ask one thing. If you don't have any history of cancer, breast cancer, do you recommend you still have a mammogram every year?
Yes.
Especially at my age?
Yes. Yes, ma'am.
Did you hear about the baby boy with 3 parents?
No, I missed out on that one.
They had to do it in Mexico. They were from Jordan. They lost 6 kids of miscarriage and things. So they took the lady's ovary, egg, ovum, and spliced it with another woman. Took the bad gene out and put the good gene in their egg, and her husband and her had a baby, a boy. But it was born in April. They don't know if it's going to turn into a freak or what, But it has 3 parents.
That's good. Yeah. I've actually seen that in other species being
Really?
done. Yes. Okay. Thank you for coming.
Yeah.